So what I'm going to talk about is kind of overview a little bit of what Parkinson's disease is, and then move on from the medical treatment to the surgical treatment. And I think that will help to set off the background information on what we're going to discuss later on. So, like I said earlier, a lot of the symptoms that are very characteristic of Parkinson's disease are movement related. And the key ones are listed here, meaning that the patient present with slowness of movement, they have more stiffness, they feel sometimes that their arms or legs are dragging. And like Ulrika was saying, tremor is also quite common. About 60% of patients may have some tremor. These are the classic symptoms. We also notice that their walking is a bit more shuffling. Some may have instability in their gait, and their facial expression become more mouse-like. I think the other thing that is maybe not as frequently mentioned are the non-motor symptoms. And actually they present very often before the movement signs. These are loss of sense of smell, anosmia. Patients can have constipation very often, sleep disturbance, some urinary symptom, as well as anxiety and depression. So these are some of the very early signs of Parkinson, even before the movement signs are apparent. In terms of what it is, like I mentioned earlier, it's a loss of a specific type of cells within the brain. So here you can see that it's paler compared to the normal side. So it's a loss of dopamine-producing cell within the substantia nigra. So dopamine-producing cells are critical for the control of movement, and with time, they disappear in Parkinson's disease. There's also a progression. So initially, when patients are first diagnosed, the disease is kind of restricted to this part of the brain, but with time, it progresses to involve more and more structures of the brain, and that's the pathological signs of what we see. So the pathology is progressive, and therefore the symptoms themselves also progress with time. So for example, if it's affecting here, there's loss of sense of smell, and here, patients have more of the constipation, urinary type symptoms. Like we said earlier, the first line treatment really is medication, and medication as well as lifestyle modification. So for example, change in diet, regular exercise. The patient have to have a routine around their lifestyle, as well as medication treatment. Now, what we do know, though, is that even though medication is really effective in symptom relief, with time, they become less and less effective as the disease progresses. And some of the statistics show that, for example, after 4 years, 40% of patients experience decrease in the efficacy of their medication. And I think this is an important graph. And essentially what we see is that at the time of diagnosis here, patients have slowness of movement, rigidity, and tremor. They have some symptoms before the premotor. The other non-motor symptom that I mentioned, constipation, sleep disturbance, etc., happens way before, more than 5 years before that they are diagnosed. And for the first 4 to 5 years, it's really a honeymoon period where the response to medication is really ideal. So medication works really well in the early stage, and that's felt to last about 4 to 5 years. After that, they start to develop some resistance to the medication. Medication dose tend to increase. The regime becomes more complicated. We have to add more than one medication into the treatment, maybe 2 or 3, and patients start experiencing fluctuations with on and off symptoms. And I think Ulrika later on will tell us some of the symptoms she experiences in terms of motor fluctuations, where you have this on and off period. Medication themselves can cause side effects. So too much medication can cause patients to have dyskinesia, uncontrolled movement, and later on, they have more and more advanced symptoms. And I think the key point I want to make is that patients should start thinking about surgical treatment at this point. So when they start having fluctuations and dyskinesia, instead of waiting till it's very late on in the disease, which is what traditionally people consider DBS to be most effective, in fact, we should think about it here when the disease is still starting to show some fluctuation, but not so much that it's really, really an advanced stage. And I think that it's important to start thinking about it here. That's really a key point I want to make. So what can patient experience when they have the medication starting to fail. So it fails to kick in. So they'll take the medication, and you may, instead of taking 20 minutes, 30 minutes to start working, they may have to wait longer. It may suddenly stop working, or we have to increase the frequency of taking it, or we may have side effects. Some symptoms become unresponsive to medication, unlike before, and it starts to interfere really with their daily activity of living and reduce their quality of life. So these are the signs that the medication is not working as well as we should be. So deep brain stimulation, what is it? And it's a well-established treatment for Parkinson's disease. It was invented 30 years ago, and it's been a standard of care for a long time. It's just maybe a bit less well known, but it's really been around for some time, since 2000. But the other thing is that because it's been around for a while, 150,000 people worldwide have had it, and about 200 patients in Singapore. That's kind of statistics around how many patients have been treated with this therapy. And increasingly, more and more patients in Singapore are also having this treatment. How does it work? Well, essentially, it's a pacemaker for the brain. And we know that so this is the patient I had, and I recorded the brain signal. And what you can see is that here, the signal is abnormal in the patient brain. And what the DBS aims to do is to regulate that signal to make it more normal. Yeah, so this is one of the patients we did the surgery on. And the system really is quite straightforward. It comprises of 3 components: the electrode that goes into the brain, the battery itself, the neurostimulator, and a programmer, which is like a remote control that the patient can use to control the stimulation strength. So it's really can be controlled wirelessly. Here's a little video to show how it works. If you look at it, there's a battery here connected with wires to the brain. It's inserted deep inside the brain structure. These are very thin wires. That's why it's called deep brain stimulation. And it's connected to a neurostimulator, which is essentially a battery. And it generates these special pulses at a specific frequency, and that essentially disrupt and normalizes the abnormal signals within the brain. Okay, and after surgery, because the device can be remotely controlled, it takes about 3 months to optimize the stimulation setting so that we get really the best out of the system. It also means that with time, as the symptom changes, it's possible to increase or change some of the stimulation setting to further optimize as the disease progresses. Surgical risks, I think it's something that I need to mention, and essentially the risk of serious complication, about 1%, essentially bleeding risk, and a 3% risk of infection. What can it really do and for patients? And essentially it's in 4 categories. So the medication is reduced after DBS is started, because it can, but not completely stop. So for most patients, they still need a small dose of medication, but the medication is reduced. The movement is easier. The walking is easier. They have less freezing, for example. And for patients who have a lot of tremors, you'll also easily abolish those tremors. Some patients have a lot of pain from their Parkinson's disease, and it will help with that. So these are the main things that DBS can help with. So this is the result of a study we did in Singapore, and essentially we look at patients before, so we had surgery here, and we are looking at prior to surgery. You can see that the patient's medication dose is increasing for 3 years before, and after surgery, we see that the medication is reduced. Yeah, this is some study we did in Singapore, showing that the results can be reproduced here as well. I think this is my last slide, and I want to say that essentially it's important to have the right mindset, and the most important thing is that DBS should not be left as a last result. I think there's this idea that it's really for very advanced for very advanced Parkinson's disease. In fact, all the data and all the studies show that it's better to have it early, because it's important to be able to preserve that function as opposed to let it deteriorate. You can, in some patients, really make a big difference and improve their function. Thank you.